this is really a beautiful, so our standard, how we do our standard congenital is we do a 6.5 cc injection and we do a timing bolus. And then we figure out where our peak is. Most of our patients, because their cardiac output isn't perfect, it's somewhere with a 6.5 cc injection is somewhere around like 14 to 20 seconds. And then I never give less than 80 cc's of contrast. And then we do it where we essentially we adjust how much contrast we give. So we're injecting 4 seconds into our mix. And so then we do a mix, which I believe is a 70-30 mix of contrast in the second. And that we're trying to inject like halfway into our second part. And the reason we're doing that, and there's a lot of different ways that you can do it, but the theory is essentially we're trying to limit, and we still have some mixing artifact, but we have less. And so we're trying to have like a little bit of a steady state while we're injecting. So we're scanning during the middle of our injection of our second injection. And so it helps reduce the amount of mixing artifacts. So it's a little bit of a steady state. So I can most of the time look at the tricuspid valve, but not 100%. So it's a modification of our tricuspid valve protocol. And then this particular case, I don't believe I gave nitroglycerin for, but with this protocol, we're able to also typically get coronaries also. So we have enough contrast in our coronaries that if it is someone that's going to be going to the OR and I don't want to cath them, I'll give them nitroglycerin to look at the coronary arteries to try to clear them. And so our surgeons are pretty conservative here. And so it was 40, then it was 35, and now it's 32. And so 32 is typically the age our surgeons want coronaries to be evaluated, which I think is a little on the young end, but that's what they want. And so I'll try to anything that I think might be able to go to the OR. The other thing that's a little bit different when I'm doing these scans for endocarditis and looking at coronaries is that I'm not looking for a perfect scan. So my standard patient for a coronary, I absolutely want a perfect scan because the diagnostic quality is better. It's easier to read. These studies, I'm more looking for a good enough scan when it comes to coronaries. So what I really want is them to be dilated. So I want to maximize giving nitroglycerin. But if they're septic and their heart rates are high, our scanner is good enough that as long as I have a steady heart rate, I'll take a steady heart rate with a high heart rate. And most of the time I can give the surgeons like enough information to decide, do I need to bypass or not? Or even if it's borderline like, hey, I think the interventionalist could take care of, whatever lesion down the line with a stent if needed, like hold off on a bypass. And so we'll get away with it most of the time. But that's our kind of standard of how we're doing these injections. Versus our coronaries, we're doing like a 6.5 or higher injection rate and going typically at +2. And then we're giving half the amount of contrast that I typically give for these congenital patients to get a biventricular scan. Does that make sense? And then this uses a lot more contrast. If I need to minimize my contrast, then I switch over and I do bolus tracking off of the ascending aorta, and we limit and we only give a maximum of like 70 to 80 cc's with a 4 cc injection, and typically that's a long enough, it's a slow enough injection with a long enough kind of column of contrast that I'll get it on both, but it won't be as bright as what I'm getting here with this. So this is a lot easier to read. And I really have not had any issues with giving the higher amounts of contrast, even in the septic patients of acute kidney injuries from this. Typically, if there's an acute kidney injury, there's a lot of other things going on. The other thing, a lot of these patients with pulmonary valve endocarditis will show up with a pulmonary emboli. And so almost all of them end up getting PE studies. And I've seen a lot of times where it's been missed by radiology that there's pulmonary valve endocarditis, and all you have to do is open up the study and window down. And so for PE, they're looking for the contrast to be really bright in the pulmonary arteries, but if you window down and you look at your replaced pulmonary valve, you'll see a huge thrombus or a huge vegetation on the pulmonary valve. And I don't even need to scan the patient. I already know that they have pulmonary valve endocarditis.